So I thought in talking about what we've learned and what we can do in the future, it would be important to understand our population. There's been a little bit of confusion between the screening population and the screening population because we have a lung cancer screening program, we have an asbestos health screening program, and then we have our overall population. So I just wanted to do a little bit of clarification and explanation of CARD so that as we try to help each other and work together, everybody understands what the population really looks like. So we do, of course, we're mostly a clinic. We do fee-for-service. We're a nonprofit, specialty healthcare. We serve the families of Libby, so our idea in being involved in research is that we want to be the conduit between the community and the researchers. And so thank you all. You already know that, but we do appreciate you collaborating with us for that. Our mission, we just changed this last year. We took out research, but we added hope, and research falls in the realm of hope. So we do our research collaborations in order to provide more hope to people so that we have better treatments in the future. Who represents CARD? We have a volunteer board of directors. I don't think we have anybody here today, but we had one at dinner last night and one here during the day yesterday. We have 24 staff members, and now we have over 7,000 patients. We're funded from a number of sources, but it's primarily from this 5-year block grant for screening, which is through the CDC. That covers the asbestos health screening, the one screening population we always talk about, the lung cancer screening, the other screening population we always talk about, and our outreach and education. So Dusty's role and all these fun little floams and things like that that we bring, those are all part of our outreach and education program. We also have some contracts and research subawards occasionally, which are wonderful, and we do fee-for-service healthcare. The Affordable Care Act really impacted CARD. It allowed us to have this screening grant that we have. It's also provided Medicare for anybody who gets diagnosed with an asbestos-related disease from Libby amphibole exposure. So even if you're 35, you get diagnosed, you have access to Medicare, which is really unique. In addition, we have a pilot program that covers medically necessary things that don't even necessarily have to be related to asbestos disease. So things like if you are having trouble staying in your home because it's wintertime and you can't shovel snow because you're short of breath, you can get somebody to come in and shovel snow for you. That'll be covered by the pilot program. It also covers mileage to get to doctor's appointments and that sort of thing. So these are all benefits that are included in the ACA. We are highly invested in the ACA, continuing for this reason because CARD would not function well if we lost the ACA. The other thing we need in order to keep all these benefits for our people is a public health emergency. So Libby is the only place that's ever been declared a public health emergency by EPA, and that's why these benefits are available. So for a while, when the EPA was talking about leaving, the community wanted to get rid of this public health emergency declaration. For good reason, because it sounds terrible and it's bad for tourism and doesn't seem like it's good for the economy, but we need it to stay. So that's just a bunch of history of the public health emergency, but the main point is it needs to stay, please.
Tracy, what is that? I mean, granted, this is the first such emergency location, but is there a sunset clause in that, or is there what happens? Does it just stay indefinitely like that?
So at least the screening portion says that until the ROD for OU4 and OU7 is completely implemented, I think is how the wording goes, we'll have a screening grant. The rest of it, I don't think goes away. I think the Medicare and the pilot will stay around. Screening services, so what we do at CARD. The asbestos health screening we do locally and at a distance, so anybody who lived in Libby for at least 6 months, at least 10 years ago is eligible for screening, asbestos screening that is, and we can do that over the phone basically. So we send the prescriptions, they get the testing done where they live, and Dr. Black or Miles will call them and talk to them about results.
So is that's a rolling 10 years basically?
Yes.
So it's not a
Yep.
day, it's a day ahead.
Right, so we're trying to give enough time. The 6 months is enough time to potentially get disease exposure, and then the 10 years is enough time for latency. And of course, people who lived here in the 70s are much more likely to have disease than people who lived here in 2000, but that is the way it works. This asbestos screening includes a chest x-ray, lots of paperwork. We've talked a little bit about the paperwork. We do exposure history, health history, spirometry, a fecal occult blood test, patient education, a provider visit, a potential HRCT, and then another provider visit. So lung cancer screening is also funded by this screening program, but it's a little bit different because you have to be diagnosed with an asbestos-related disease for the most part to get involved in lung cancer screening. So you would go through regular screening, get diagnosed, and then the next year you'd start lung cancer screening. No application required. You have to have at least 20 pack years of smoking history and be between 50 and 84. The lung cancer screening is a low-dose CT, and that's read by LCAP. Our healthcare services are not grant funded, but we do have patients who come in for regular annual visits with Dr. Black. Asbestos programs and money, this has been a source of a lot of confusion. Basically, CARD does not deal with legal issues related to asbestos or refer to specific attorneys. Over the past 20 years, there have been a lot of different programs that do different things to help people financially. We're not really involved in any of them. We, of course, send medical records, but other than that, it's not our territory. CARD's direct community impact. We do about 700 people a year in the asbestos health screening, free smoking cessation for anybody. Lung cancer screening is up to about 600 people a year. It started with about 175, so we've really grown that program. 24 jobs with full benefits, free education and outreach events. We support the local economy with about $1 million a year.
Is that increase because there's more people being diagnosed with asbestos-related disease, or just because?
The lung cancer screening increase? Yeah, I think it's as people get diagnosed and as people come in for their annual visits, our doctors will say, oh yeah, you should get a lung cancer screening, you have a smoking history, and so they kind of get signed up as they come in for their regular visit. So this was kind of an attempt to explain the population. So asbestos screening population, they, of course, when they got into that asbestos screening population, they were undiagnosed, but many of them are diagnosed now. And then we have this group of patients, the bar on the right, are people who were already our patients before 2009 when these screening programs started. And so the lung cancer screening, although we have about 600 people now, is still a pretty small proportion of CARD's actual population. So Lincoln County, Montana still has the highest asbestosis mortality rate in the US based on, that's a NIOSH publication, I think that happens like every 10 years. The rest of it you guys already know, but we don't have any good updates on mortality, and we haven't in years. And so that's something that we really are looking forward to trying to do. The NIOSH mortality is based on death records, and I can guarantee, I think Dr. Black said it yesterday, that death records are wrong a lot of the time. And so finding a way, we've tried to publish a mortality study and it hasn't been published, we're working on it again. But finding a way to do a mortality study to explain how many people have been diagnosed and morbidity and mortality would be amazing. So Jean had said the bottom bullet point already. We have over 5,000 people enrolled to participate in research, and 97% of people that are approached always say yes. We offer lots of opportunities. It's called our all-inclusive consent, and we say, hey, can we use your data in a research database? And that's what most people say yes to. But we also ask, hey, after you die, would you mind donating your lungs to research? And I would say about 50 or 60% of our patients say yes to that too. So there's a lot of support for what we're doing. And that's pretty much else. We're pretty much it. Where do we go from here? New screening grant to potentially include ANA testing. We're pretty excited about that. Mortality study updates, we just talked about that. And we're open to all kinds of different studies. I always like the idea of getting grad students to look at our data and help us because we don't have time to do it ourselves.